Because Mrs. Tubbs is a COPD patient who requires careful weaning, we want to be aware of her specific arterial blood gas trends. So let's ask this question. What are her typical arterial blood gas or ABG values like?
Mrs. Tubbs is a COPD patient, so her typical ABG values will look different from those of patients who do not have COPD. For her chronic condition, remember her pH will be normal. Her PCO2, which is showing us how well she's ventilating, will actually be increased. Her PO2, keep in mind, as much as she's getting from her nasal cannula or other oxygen device, will still be decreased from what we would hope to see for a patient. Her bicarb will be elevated because it has compensated for that elevated CO2 and that already normalized pH. Her SpO2 will also be decreased. Keep in mind that for chronic conditions, we always will have a normal pH. So for Mrs. Tubbs, this is the typical trend we will see in her ABG values.
Now, there are a number of special precautions we must take in initiating a weaning protocol for Mrs. Tubbs, given her past difficulty in weaning. I first want to confirm that she has been participating in the VAP, or Ventilator-Associated Pneumonia Prevention Protocol, for several days. This includes the head of her bed being elevated above 45 degrees, daily withholdings of sedation medications, peptic ulcer disease prophylaxis, as well as deep venous thrombosis prophylaxis. This prevention bundle helps ensure that Mrs. Tubbs does not develop a new complicating respiratory condition that would extend her stay on the ventilator and postpone her extubation and liberation from mechanical ventilation. I have presented here a list of physical standards Mrs. Tubbs would need to achieve in order to begin a weaning therapy. This is designed to help assess her readiness as well as confirm that she is physically up to the challenge of beginning to breathe on her own. As prescribed by her physician, here are her current ventilator settings.
Her vital signs are normal and stable considering her age and cardiopulmonary disease history. Currently, her SpO2 is 91%. Looking at her monitor, I've noticed the following values that I will document in her chart. Currently, her heart rate is 89 beats per minute. Her respiratory rate is currently 16 breaths per minute. Her blood pressure is 110 over 89. Her body temperature, last recorded, was 37.4 degrees Celsius. At the time of writing all of this down, her SpO2 is 91%. Our attending physician, Dr. Nose, has asked me to wean Mrs. Tubbs' rate down to a rate of 4. Mrs. Tubbs is currently on a setting of 10, if you remember. That means that Mrs. Tubbs needs to go down 6 breaths per minute. For a COPD patient, that's a big drop. So as the respiratory therapist, I'm going to wean her rate down about 1.5 to 2 breaths every 3 to 5 minutes, watching Mrs. Tubbs to make sure she can tolerate these changes. If she's successful, we will continue to wean her down to the final rate of 4 as prescribed.
These settings will be weaned down as tolerated by our patient in order to comply with our weaning protocol. Managing these settings helps us to understand how well our patient's lungs are able to spontaneously ventilate and oxygenate her body. Also noted, Dr. Nose has not given any specific orders this far to change Mrs. Tubbs' settings on her ventilator. I will monitor her oxygenation and ventilation status non-invasively by monitoring her end-tidal carbon dioxide capnogram reading as well as her continuous pulse oximetry reading. I will also continue to monitor Mrs. Tubbs' ventilation or CO2 level and oxygenation or O2 level invasively by obtaining an arterial blood gas analysis from an arteriotomy. During this time, I will also monitor Mrs. Tubbs for any signs of distress. This includes an elevated CO2 level or decreased O2 level, any tachycardia or an increased heart rate. I will also watch her EKG tracings for premature ventricular contractions, indicating to me that her body is hungry for oxygen. I will also watch her use of accessory muscles and her work of breathing. I will also monitor her for dyspnea or the difficulty of breathing. I will watch her skin color as well as assess her for diaphoresis. And finally, I will just check her abdominal muscles and abdominal area for thoracoabdominal paradox.
If your patient is in distress, you can be certain that with a few visual assessments, you'll be able to tell that your patient is having difficulty breathing. Be certain to always change your latest settings back to whatever was most beneficial for your patient, returning them to a better level of comfort.